Hi there. My name is Dr. Shona D'Arcy, and I'm going to give you a brief overview of voice technology in healthcare. So, brief overview of myself. I did a PhD in speech recognition technology in 2005 in the University of Birmingham. And the focus of this was really looking at two types of speech that were causing an awful lot of problems for speech recognition. They had very poor word error rate, which is the metric we use to measure the accuracy of a speech recognition engine. I've been working in digital health for the past 15 years with and without voice technology, and I'll go into some of the projects that I worked with along the way. So before we start, I just wanted to give a quick overview of speech and how we generate speech, because it really does impact how we think about applications for it. So I guess speech is it's a really interesting signal that we generate as humans. So it starts in the brain, where we have to plan out what we're going to say. And of course, all of this is done subconsciously. So we need to know what we want to say, and then we have to break that down into the components of speech sounds, ensuring that the syntax and the grammar and what we're saying makes sense, and then break all of that down into the individual speech sounds that make up coherent speech and language. And then all of those have to be transmitted down to our physical articulators to make sure that everything moves correctly and in the correct order in order to make coherent speech. So it's a really complex process involving lots of different physiological components, cognitive and neurological components. And that's one of the reasons why speech is so interesting in healthcare. So not just as a signal for transmitting language, but also, as we'll see later, some really interesting opportunities for integrating into the healthcare system as an actual diagnostic tool. So in my research, I was looking at, as I mentioned, two components of speech that were particularly difficult for speech recognition, and they were accents. And the reason I talk about this is because it really comes down to a core component of speech recognition technology, which is training. Back in 2005, speech recognition engines tended to be trained on standard Southern English and standard American English. So there was really no accommodation for the nuances of accents. And just to give you an example of what that can look like, this is a vowel plot for all of the vowels in the Irish accent and in the London accent. And you can see here there's two distinct clustered sounds for, I think that's heed and hid. But over in the London accent, there's a clear confusion between these two sounds. So if you don't have training examples of all of these different accents, then the speech recognition engine is not going to work. So with accents, it really comes down to more the lexicon and accommodating the variety of accents that can occur. I also looked at children's speech, and this caused problems for speech recognition for a very different problem. Children are smaller, they've got smaller vocal tracts, and because of this, their frequency profiles are normally are normally much higher than adults. So whereas the adult speech recognition engine is trained on on adult speech, when you try and put a child speech, run a sample of child speech through this, it very often doesn't work. And you can see here why. So the children's speech, the vowel triangle, is a factor of about 20 higher than, sorry, not a factor of 20, it's about 500 hertz in the difference between the frequencies here. So there's really no overlap between the vowel triangle for an adult and for children. And that's where the issue came from. So a lot of work was done on adapting these baseline speech recognition engines to different types of speech. So instead of having to build a speech recognition engine for every single accent, you throw in a lot of the data, you add in all of that data to increase the variability and increase the training data. Similarly with children, now there has been a lot of work now in actually building speech recognition engines specifically for children because the variance is so different. But I guess what I'm trying to say about trying to demonstrate with these is that it's all about the data that's used within the training set for the speech recognition engine. That can affect the performance. So if you're building an application for speech recognition, you do need to think about the training data that's gone into it. So as I said, I worked in digital health, and again, just some interesting projects that do relate back to speech, and kind of I've seen the growth into digital health and how speech works through them. So my first project was speech as a biomarker for early signs of cognitive decline. So we were looking at how could we use people's voice and their ordinary conversations to understand the difference between general aging and slowing down and the onset of cognitive decline. In this project, we were looking at using voice interactive services to administer cognitive assessments, which is not particularly groundbreaking, but also looking at analysing the signals. So how fluent was the person's speech, and was that changing over time in a significant way that would correlate to a diagnosis of cognitive decline. I worked on a smart inhaler and a non-invasive neuromodulation digital health project. And both of these were about bringing technology into patients' lives. And I don't think you can talk about voice and digital health without talking about the patient and their lives. So you really have to think about this, you're bringing accessible technologies into patients' lives, but you're also, making them very much aware of their illness. So for example, if you're asking someone to track their mood every week or every day, you're bringing them back to think about their mental illness or their, whatever the reason for tracking their symptoms are. And that can be hard. So there's a lot of user design around how you bring these technologies into patients' lives. And I think that is one of the great opportunities for voice applications, but it's also something to be very, very mindful of. And I said voice user interface design. So speech is a great tool if it's done correctly. We've all been on those banking applications or booking your cinema where you just feel like you're a robot. So there's a lot of work going on now with the voice user interface, particularly with the expansion of smart speakers. So there's a whole science behind how you build your recovery strategies, your confirmation strategies. But again, when you build voice applications in healthcare, you're now talking about patients. So you're talking about vulnerable people. You're talking about people who are concerned that their very important clinical data is getting shared with their physician. So you really do need to spend the time testing and understanding your users to make sure that they understand what's happening, they're comfortable using their voice. So it's not just a case of getting the technology right. It's very important to make sure that you get this voice user interface design right. One of the things is, I guess, it's a real conceptual thing. If you fill out a form and press send, you know where that data has gone. When it's voice, particularly on a voice, on an Alexa or a Google speaker, you don't see that, you don't get that real haptic feedback of knowing that your data has gone and getting that response. So those kind of things are important, particularly when it comes to healthcare. Just to show you the opportunity size, the funding going into the voice market is all going into healthcare. 47% of funding, I think this is 2018, in the voice market went into healthcare because there are so many applications and it can generate such wins for the healthcare industry. So the first application I want to talk about is physician documentation. So this was seen as one of the earliest wins for speech recognition in healthcare. You may have come across the recent acquisition of Nuance by Microsoft. So Nuance were one of the first companies to really take speech recognition in the healthcare system seriously. And the challenge for Nuance was, again, comes back to this idea of training data. So if you use a normal off-the-shelf speech recognition engine, it's going to be trained on a large amount of speech collected probably over the telephone or, you know, smart speakers. But it's not going to have an awful lot of medical terminology in it. So if you use an ordinary speech recognition engine and try to use a very complex medical terminology, it's not going to have a very high accuracy rate. So what Nuance and a lot of these companies have done is they have increased the training data of the medical terminology to improve that word error rate, which means now doctors can dictate you know, complex medical terms like hematology, cardiothoracic, I don't know, and they'll have a high accuracy rate, and they've been building up this training data and making it more and more accurate for the last 20 years. Obviously, the huge benefit to this is a time lag or time saver for physicians. So constantly you'll hear from physicians that the biggest suck of their time is writing up patient notes. And the process of dictating them and having them manually transcribed is very expensive and can be time consuming. So we now have something that is a lot more efficient. You have an audio recording, so you always have a record of the original transcription. And by, you know, translating records directly into a transcribed file, you have the opportunity to go straight into the electronic healthcare records. So as everything is becoming connected, it works really well. However, it's not perfect, and this is healthcare. So physician notes still need to be checked, because a mistake in a dosage or a mistake in a come every 6 weeks as opposed to every 6 days can have a real impact on patients, particularly when it comes to dosage. That things can be a patient can die if a dosage is out by a factor of 10. So it's saving time, but it's not there yet, and it will always need to be checked at some level. And of course, this is one of the reasons behind that reticence for digital health within the healthcare system. And in fact, one of these companies really demonstrate what I'm talking about here. They were a transcription company, so they received audio files, dictation files from thousands of doctors over a long period of time, over 10 years. So they had all of that training data at hand, so it was transcribed accurately. So they then moved into speech recognition and started building out their own speech recognition, because they had that really accurate ground data to start from. Patient engagement is another really interesting application for speech recognition, and the two most obvious cohorts are older adults and disabled users. And these are two groups of people that don't necessarily have the proper dexterity to be using smartphones and tablets. So voice really opens up access to technology in a way that it hasn't in the past. There's a lot of work in older adults around kind of being able to access community care, and there's some work around robots with older adults. This is still kind of in the early stages, but there has been a lot of work around just allowing older adults to diarize their history and allow them to feel active and to do a lot of things, particularly when they are bedbound. So voice opens up the world a lot, and disabled users particularly. Voice has opened up the opportunity to participate in the world a lot better. Voice applications allow an awful lot of adherence tracking. So are people doing their physio? Are they taking their medication? And patient-reported outcomes means that the documentation and the tracking of all of these medical touch points has become so much easier, and you can now share it with physicians a lot quicker than in the past. But this is where it gets really exciting, is vocal biomarkers. So as I mentioned before, I had done some research on cognitive decline in older adults, and we were looking at their ability really to process and generate coherent, fluent sentences, and how often were they having to insert pauses and disfluencies in order to catch up with the speech that they're trying to speak about. And there are companies looking at that at the moment. Parkinson's disease is a particularly appropriate condition for speech, because it has a physical and a cognitive component to it. So Parkinson's starts with the tremor that we all know, but that tremor can also be found in the vocal cords. So when a person with Parkinson's is generating speech, when the vocal cords are vibrating, instead of having a nice kind of smooth fundamental frequency, there will be a lot of noise in that because the vocal cords aren't vibrating correctly. And also the cognitive decline that can come with Parkinson's disease is all, kind of part and parts, can all be identified through speech. So that's more of a physical one. There's been a lot of work on looking at the neurological and the cognitive processes associated with speech. So, for example, depression and schizophrenia. In depression, there's been a lot of work around. So when we speak, we accommodate the people that we interact with. So our pitch changes in line with the person we're speaking with. The speed at which we speak accommodates to the person we're speaking about, and it's all these little cues for engagement. However, when people are having depressive episodes, this tends not to happen, and they tend to be very flat, and they don't add in those cues, such as ums and ahs, and you pause your speech to let the other person speak. So a lot of these get missed when people are having depressive episodes. And I think in schizophrenia, it's slightly different, where the speech can be quite manic. And it's about comparing those features of your speech from depressive episodes to normal episodes. So it's a very good biomarker for identifying depressive and schizophrenic episodes, as opposed to diagnosing it just in a general population. And then, of course, couldn't have a talk without COVID. Canary Speech say that they were able to identify COVID in a cohort of speakers with very high accuracy. And that kind of makes sense. It's a respiratory disease. So it will be affected, the airflow coming from your lungs into your vocal tract to generate your speech will be affected in some format. So there's many opportunities here to integrate voice as a diagnostic tool within the healthcare systems. So why haven't we seen it? Why aren't we all doing voice dictation tests to diagnose asthma and cognitive health? Because really the research is there's two sides to this. There's the privacy and the security, which is always a challenge when it comes to voice, because of first of all, if you're collecting voice through, say, a smart speaker, your husband might be ordering pizza in the background. So while you're trying to anonymize the data, you get the person's address in the background. And different people would consider voice as a personal identifier. So if anybody who knows me heard my voice, they probably would know it was me, but an outside person wouldn't necessarily be able to identify my voice. But it could be used with other data to be able to identify me as a person. So the security and the privacy issues are still haven't been resolved. as to whether voice is it's the same as your email address or your postcode. But it's something that is going to be more and more in discussion, I think, in the coming years. And the other real problem is, I think, efficacy. So there's been a lot of research papers claiming diagnostic abilities of voice for all of those conditions that I spoke about before. But they're really in the lab. So they will take a set of users, with COPD and a set of users without COPD, and they'll build a scoring algorithm and they'll get a high accuracy. But that's really, I guess, in the lab. We aren't really seeing clinical trials of equivalency. We're not seeing randomized control trials to show that actually it is effective in the real world as a diagnostic tool. And I think we're about to see that. Like I said, I think the research and the in-lab research has shown really good results to date. And I think the next step that we're going to see over the next 3 to 5 years is a lot of trials on clinicaltrials.gov, and a lot of robust data coming out to demonstrate voice as an accurate diagnostic tool that can be used within clinical care pathways. So that's been my whistle-stop tour of voice in healthcare. Personally, I think voice is a fantastic window into human behavior. The processes required to generate coherent speech are so complex and cover physical and cognitive processes that we have a great opportunity to understand how we degrade through speech. But I think the jury's out as to how efficient it's going to be within real world settings. So I'm looking forward to seeing more and more evidence coming out in the next few years. So this format doesn't really allow for questions, but if anybody would like to reach out to me, please find me on LinkedIn. That's the best place to find me. And I'd be more than happy to answer any questions or talk about this further in any way. So thank you for your time today. Goodbye.